everyone, and thank you for having us along today from Tayside virtually to talk you through our patient demand and flow management system that we use currently within our acute hospitals. My name's Susan, I'm one of the Associate Directors for Acute Services, and a part of my role is supporting the safety and flow arrangements on and between our acute sites. And I'll talk a little bit about that and how we use our data and information to help us to do that in as effective a way as possible.
Thanks, Susan. Hi there, I'm Jenny Woods. I'm the Health and Business Intelligence Lead within NHS Tayside. I manage a team of information analysts and dashboard developers. We work with Susan and teams across NHS Tayside to help them with data around patient flow, patient activity, trying to understand what the whole system looks like, really supporting the kind of data-driven organisation.
So as you'll see as we go through our slides, we very much have a collaborative approach, and part of the model we're most proud of is the way that our clinical and managerial and our business unit teams work together to produce this really meaningful and relevant suite of information that supports real-time flow and safety and clinical decision making. Jen and I over the past couple of years have become the self-styled Elsa and Anna of winter planning for NHS Tayside, and much of what you see today has developed through the various iterations of response planning around the COVID pandemic and winter planning over the last couple of years, historically those being our peak demand time, so they provide a really good test environment for much of the intervention and information use that you'll see as we talk through. So first of all, a little bit about Tayside for those of you who are not familiar. A lovely picture of Dundee, which is I think the sunniest city in Europe, up on the screen here. Some numbers there just to show the size and complexity of the patch that we work across. So with acute services being hosted on the two main hospital sites, we work across 3 health and social care partnership regions. We have obviously a national ambulance service in Scotland that is deployed regionally as well, so we have links obviously closely with them. Our 2 emergency departments and our major trauma centre in Dundee. Geographically, we are quite a diverse patch, so we go from the northwest and northeast of Tayside being quite remote and rural and accessible by air majoritively of the time for our major trauma patients, and being probably a good hour and a half away by road from our acute sites, to our urban areas in mostly Perth and Dundee, which have all the same challenges and complexities as most other urban areas have in Scotland and indeed the UK. So thinking about the challenges that we faced, particularly in acute services, these will not be new to any of you, I wouldn't have thought. Patient flow through the acute hospital sites, both being able to admit to the right place at the right time without delay or wait, and also being able to discharge people to the most appropriate place closer to home, being our primary issues that we had, and maintaining appropriate admitting capacity and occupancy levels within our hospitals. We know that if we function at a certain degree of occupancy, our quality of care is much better, and we're able to enable the best patient pathways. In terms of thinking about our information, so a lot of the information we would get would be retrospective. It would lack clinical narrative. We would find ourselves sitting with clinical teams at the end of the month or at the end of a quarter, benchmarking, looking purely at numerical values and performance against standard, with very little of the relevant clinical stories wrapped around those numbers, and often with the lag in reporting that we had built into our system. By the time we came to review that information, it was very difficult to then use that to improve quality or to improve patient pathways, because we'd lost the stories around the numbers. This obviously led to a degree of clinician disengagement, because the numbers didn't feel like they were useful to our clinical teams. They didn't feel like they were reflective of the challenges or indeed the successes that they were experiencing on the front line. And it wasn't a useful thing in many ways for meaningful change. It was more of a measuring for measuring's sake. However, as we went into the response to the COVID pandemic, and indeed as we came to remobilise, and again thinking about our other periods of peak demand, it became quite evident that actually there was a place for real-time, clinically relevant, meaningful data, and our teams were keen to engage with something that was going to support them to work differently and to improve the quality of care that they were providing. So thankfully in Tayside, we are extremely lucky to have a very engaged business unit team who were able to help us to work with these challenges. So visibility and relevance are the real keys to our success in Tayside around using our data in a meaningful way. So Jen will talk much more as we go through about the how, but certainly the why around developing Command Centre and the way that we use it was very much predicting the unpredictable. So we have a huge amount of unscheduled care that for a long time we worked under the apprehension that there wasn't really an awful lot that we could do around scheduling it or indeed understanding or predicting it. However, working through this process and working really closely with the clinical teams, it was evident for them that there actually were some metrics and some numbers and even just some feelings in the system that whereby they could predict when they were going to be busy. And actually, if we could map in real time our demand, there were things that we could put in place further downstream to support that activity and try to eliminate the bottlenecks that were really evident in particularly our acute admissions and discharge processes. And I'll hand over and let Jen speak much more articulately than I can to how Command Centre came about.
Thanks, Susan. Yeah, with that backdrop, where we got to was there was a command centre that had been designed by developers within NHS down in the University Hospitals of Morecambe Bay. They had shared this information on LinkedIn and seen it as a really interesting post to think, I wondered if we would be able to provide something as clever as that, a really kind of a whole system view of the patient flow moving through in a much more near real-time basis. So the way that we approached it within Tayside was the first step was really to engage with our senior management and clinicians to understand if there was an appetite for working with us to design a Tayside version. We then were able to link in with our Click dashboard suppliers, Catalyst, and they were able to really give us a solution and an option that we would be able to use the toolkit that was designed and developed within Morecambe Bay, kind of lift that and then place it within NHS Tayside based on information that is regularly already captured within our patient administration systems on a regular basis. We've got admissions, we know the ambulances when they're coming in, we know how many people are attending the emergency departments and when, and we've got all of that information down at patient level. So it was really all we required was kind of small minimum data sets to be able to build our own Tayside version of that. Once we'd got the senior management engagement and been able to work with the consultants, the service leads, the patient flow teams, etc., to understand what the Tayside version would look like, we were then able to bring our Catalyst colleagues on site to help us build the Tayside version and how it would look. The build itself, when they came on site, actually only took us 3 weeks to design because it is a minimum data set with the data that we're already capturing. Being able to design and actually pull the information through on an automated basis was really quick. The initial kind of build and the information that was flowing through, it would reload on a sort of 90-second basis at that time, because it was really then giving us that picture over. You have your ambulances coming through, you have your emergency department, your activity, being able to then view all of that cohort by how long patients have been in, how long they've been waiting, by demographics, how old are the patients that are coming in or how young as well, if being able to kind of highlight the pediatric demand as well, flowing through then into the inpatient beds, where your bed occupancy is, where your empty beds are, really understanding the flow of the system, then being able to work with the medical colleagues. You'll see here a quote from our Associate Medical Director, really as a senior clinician, being able to understand the capacity and flow. It's invaluable to be able to see that near real time, to be able to then understand what decisions need to be made, rather than going along to the patient safety and flow huddles, for example, with lots of different bits of paper, whereas duty managers off-site trying to phone around boards, etc. The command centre is based on a kind of web URL that anybody has been able to access as long as they've got the secure kind of VPN access for NHS Tayside internet. You can then drill down. We've designed now 2 command centres. We have one within Nine Wells, our main acute hospital site, and we've also got one within Perth Royal Infirmary, our other hospital site across, which is quite smaller and has different capacity and flow issues. So it's helpful to be able to drill down and be able to get the different view for the different areas within there as well. What that then allowed us to do is release the command centre within a 3-month period. We then started to see the functionality within the command center, and you could actually expand it even further, capturing all of this information and having it visible and transparent. First of all, in the first release of the information, the data didn't maybe always quite reflect what the services and the ward staff felt for their particular area. So it helped improve data quality because people could then go back and have a look at their floor plans, understand how real time they actually were capturing information. Sometimes they were spending maybe more time filling out a red book or filling out spreadsheets, capturing admissions and transfers, whereas we were able to help them understand that if they entered the information into TrackCare, into our patient administration system on a reasonably real-time basis, that would allow, that would really negate the need for them to use any of these other data collection systems, and they could use the command center real time to be able to get that information out again, and the value of that, having the kind of right information at the right time. Then having all of that baseline information in there, you can then start to explore what else is possible. We then worked again with Catalyst to embed R within our command center. So we now have predictions within the command center to show as soon as a patient has been triaged within the emergency department, how likely are they to then go on and be admitted and require an inpatient bed. There's various different fields that we've used. Again, information that has already been captured by the ward clerks or the wards themselves in our PAS system. So having a look at postcode, age of patient, what their initial diagnosis and their initial triage was, you can then understand really how likely they are to then go on to need a medical or surgical bed. Historically, we've been pulling this information now and it's about 87% accurate, so we can then drill down, identify those patients in advance and start different conversations early on in that patient's pathway. We then also have the element that if you've been admitted as an inpatient, how likely are you to become a delayed discharge or what's maybe called a bed blocker further down that patient's stay. And again, what that does is we've got our quote here from our chief executive is it's allowing us to then predict and anticipate. You can then start different conversations earlier in a patient's journey with the patient, with family, with other people that are then supporting that flow. We have a strong relationship with our health and social care partnerships as well, who also use the command centre information to understand how we can help to pull patients through the system as opposed to kind of bottlenecks and pressure areas. When COVID hit back in March 2020, there was a huge desire to then understand the COVID position. So again, we then were able to use the command center to provide that, and we still use the command center for the COVID position on a daily basis currently. It's really has been pivotal to how we've managed and how we've understood what the position is across the service. So because we were able to design and work with Catalyst to we now have basically business informatic developers which work in our information team. And the command center set up in the background is reasonably straightforward for a developer to go in and copy the logic and be able to create our own key performance indicators. So the developers within my team were able to create a kind of gold command center front page to understand the COVID position. And it was designed and built within 3 days using alert functionality which exists within our patient administration system. We had the ward staff adding an alert on to patients to understand whether they were COVID confirmed, suspected, close contacts, and all of that information now triggers on the front page of our Gold Command screen so that they can understand what's going on regardless of where we are. We then use this information and it was sent out on a daily basis to about 160 different people across the army, across GPs, across prescribing and pharmacy, health and social care partnerships, alongside the kind of acute element as well, trying to understand what the demand is and what the current position, alongside the position with ED, delayed discharges, etc. The next element that you can do within the command centre is the predicting demand. So trying to understand what we do is we use this as part of, we've got a wider heat map that we use, which is a whole system heat map across the organisation. So having a look at the previous 7 days information, how did the predictions actually map back to the actual? And as Susan mentioned earlier, being able to actually predict the unpredictable has been really strong for us. And unscheduled demand within our system is much more predictable than we would ever have imagined. So we now use this to be able to understand what the demand is going to look like over the next 7 to 8 days. And then we can predict in advance, when do we need to try to turn our patients around? Is it going to be a Thursday? How busy are we going to be on a Sunday, etc.? We then also used this concept to understand and break it down within particular areas. So having a look at mental health wards, having a look at paediatric wards, different areas within the system. We took it a stage further and created trigger points and escalation. So there's now kind of trigger page as well that indicates what's our current system looking like. And if, for example, we've had more than 5 majors into ED within the last hour, there's a trigger, there's an alert, and they can then, this escalation policy kicks in. People can start phoning and finding out what's going on. How can we help, as opposed to people within ED, for example, having to then try and contact people within an already extremely busy department. So the predictions have been really crucial, and they're really very accurate compared with what we would have expected. It's been really fantastic getting the feel back from the ground that it is how it shows within the command centre. I'll pass you back to Susan now to kind of show from a service level how important all of this has been for them.
Thanks, Jen. I think I'd be keen from a service and an operational perspective to really emphasise the massive amount of value that those predictions and triggers bring to your situational awareness, not only in terms of being responsible for your own department and your own department's performance, but from a hospital site and indeed a strategic whole system perspective, being able to have that immediate overview of the performance of your system and knowing that there is clinical intelligence built into that around these triggers. The triggers aren't ones that we've taken from numbers based on days that performance has been good or bad. They've been taken from engagement with clinical teams saying, I know when I have those 5 admissions into my major stream in ED within a specific time period, it takes time to work through those patients. They are the sicker patients. They're the patients who are more likely to be admitted. They know that that is a significant demand. Therefore, we've built that into a system that now flags widely, as Jen says, to just reduce that demand on teams, to escalate the fact that they are experiencing pressure and enabling those of us who are in supportive roles to deliver that support in a meaningful way, because alongside the triggers, and as you'll see here, alongside the trigger system in general, we have developed a kind of pre-agreed and predetermined escalation level. So our activity level each day shows on the front page of our command centre and forms the cornerstone of our hospital huddles, which take place 4 times a day and that utilise that information within command centre. So our teams know on any given day, based on data and information, what level of pressure we are functioning at as a system, and strategically what it means for them. Underneath these strategic actions, each ward and department knows at whichever one of these escalation levels which actions are relevant to them. So I suppose this is all designed with the theory of being able to be proactive around our demand and being able to improve flow for our patients. So these are really the benefits that we have seen that are widest ranging in Tayside. I think we're always finding benefits to working in this way that I suppose were unintended at the beginning. Patient flow and performance is of a high standard in Tayside, and I firmly believe that much of that is around being able to make decisions and have discussions with real-time information and situational awareness available to us. Certainly in terms of managing our COVID response, being able to show and to continually monitor the demand between our COVID and our non-COVID streams, made those decisions around changing footprint and moving staff groups much better informed. And one of the real benefits is engagement. So we have now a common language that we use when we're discussing activity, when we're discussing demand, and that goes across our health and social care partnerships, across our ambulance service and across our mental health service. So it's enabled some really constructive conversations about patient flow, and our clinical teams, both operationally and strategically, are really engaged in this work and really, really supportive, when I think being able to see that they can have their information presented to them in a way that they find meaningful has enabled some really innovative change. As I mentioned at the start as well, all this work underpins all of our response planning, be that around our major incident planning and how we would use Command Centre to take a snapshot in the event of that type of incident, through winter planning when we can think about how we would flex to meet specific demand, or indeed when we're thinking about our remobilisation, we can also look at our planned care alongside that predicted unscheduled care, so that we can make an informed decision around how much planned care we're able to operate at any given time. Yeah, and there are, as I mentioned, other benefits to working in this way as well. Being able to automate a lot of this information and escalation has been hugely powerful. It's taken that demand from our teams who are working in these busy areas to be able to flag that there are capacity or demand issues, and to have those pre-agreed actions takes a lot of time out of phoning around and bleeping and trying to get support. And having that single source of truth is, as I mentioned, extremely powerful when it comes to having discussions. Everyone has a different tolerance level for busy. So both at hospital huddle level and more strategically with conversations between partners, being able to evidence what your level of busyness is and to have that being a clinically informed position is extremely valuable. The support that we get from our business unit team and from our wider partners to use this tool and to change this tool, it constantly adapts. We're constantly redefining our triggers and redefining our tolerances, is extremely helpful. And being able to assure our teams that the information they're seeing at their ward level around their demand is exactly the same as our chief executive is able to access from his office, is really powerful. That we're all looking at the same thing and responding appropriately. So thank you for listening to us talk about Command Centre. Jenny and I would be happy to speak to any of you around more detail or share some more examples of how we use this tool. It has become a really invaluable piece of how we work in Tayside, and it has changed the way that we frame a lot of the work that we do around safety and flow. So we would be very keen to share more of our experience if that would be of interest to anybody. And essentially, all this information exists out there, and Command Centre has given us a really powerful way to engage our clinicians and primarily improve quality for our patients, whether that is pre-hospital, during their stay, or to facilitate an appropriate discharge. So I think we can show that Command Centre is a real life demonstration of using information to provide the best quality care that we can. Thank you.
Thank you, everyone.